Tardes para todos. Vamos
Good
a dar
afternoon, everyone. We will allow a few more minutes because most participants are just getting connected. Thank you all for being here, for attending this wonderful activity.
muy buenas tardes para todos.
Good afternoon, everyone. Welcome
Esta gran iniciativa
to this great initiative
intercontinental. Estamos hablando
and
del
intercontinental initiative. This is the first symposium, virtual symposium on PBM. Thank you to all the participants who are now online
de todo el territorio americano.
across the American
Un
territory.
saludo muy especial a nuestros panelistas.
We would like to greet our panelists and our sponsors.
Iniciando
We are now starting
nuestra actividad con 363
our activity with 363 participants.
Muy bien. Estamos en este momento atravesando momentos difíciles.
We are now traversing really difficult times, uncertain times, but with plenty of opportunities ahead. The scenario of pandemics has brought a true challenge to ourselves. And right now our life has completely changed. Let us welcome officially the first virtual symposium on ROTEM for Latin America. Specifically, we know that the World Health Organization warned that for many countries, this would be a very difficult situation in terms of shortage of resources, and among them blood components as one of the very important resources so that we can offer quality service to our patients. Right now, there's shortage of these components, and so we decided to come up with this very important event, which forces us to teach an array of information and all the alternatives that are available to try to reduce the overuse of blood products. In this concept, in this idea, patient blood management is a concept that is worth taking into account and implementing right now.
Un gran grupo de
We have
panelistas.
a wonderful group of panelists. First of all, we have Dr. Klaus Gerlinger.
Muchas gracias, doctor Gerlinger.
Thank you, Dr. Gerlinger, for being here. Similarly, we will have many sessions. They will take place every Friday from the next weeks, from July the 17th until September the 4th, from 1 to 2:30 p.m. Mexico time. These activities will include a simultaneous translation to different languages. And we will also have room for Q&A sessions. We invite you to share your questions through our chat room. So first of all, I would like to welcome you and present my co-chairman. He's an anesthesiologist and specialist in hemostasis in the Department of Anesthesiology and Intensive Care Medicine at University Hospital Essen in Germany. Dr. Gerlinger will lead the sessions, and at the end, he will offer a summary of all the concepts that we will use in all these spaces. Please let us welcome Tatiana Urrea. She's the General Director for Latin America in distribution for Werfen. Hello all. I hope you're all well in this afternoon. Thank you, Dr. Arisa, for the wonderful introduction. Basically, today, as a company, we're very honored to have your presence, each and every one of you. We're very thankful that you participate in these areas. And we as a company make sure to invest a lot of effort, love, enthusiasm in what we do. And like Dr. Arisa pointed out, we're in the middle of a very complex crisis. The issue with pandemics has not only generated loss of human lives that have been very significant, but also consequences that we still haven't seen. One of these consequences, which lurks on the horizon, will be the shortage of blood. And this is something that is relatable to many people. I think we can all see that. If patients cannot get out of their houses, of course, blood donations will be reduced. They are reducing right now. And there's still a long way to go in this reduction. So there will definitely be blood shortage. And this will certainly make that every day PBM becomes much more important. And we as a company at Werfen have very important goals. The first one is we are engaged with training, with education. We have a commitment to supporting all of you in your scientific knowledge that will lead you to become better professionals. And then on the other hand, we want to offer solutions in terms of devices, instruments, reactives that we as a company have, and we do this within our portfolio. So I wanted to welcome you all. We're very excited to have you all here. We hope this will be a space for mutual enrichment with all of your experiences from so many countries and your knowledge that this exquisite panel will offer during these weeks. So welcome all, and thank you so much for being here. Thank you, Tatiana. very encouraging words that prompt us to turn these set of conferences into a wonderful academic movement. We would like to welcome Rafael. He's Rafael Hack. He's the manager for WERF in Brazil. Thank you very much. I will speak in Portuguese. I represent Brazil. First of all, I would like to thank for the invitation and this initiative that's very important for everyone, especially for the continent in our region. Latin America has suffered plenty this impact, and I'm very proud that I can be part of a company that can offer this type of seminar that's an educational seminar so that a problem that is already so serious, such as blood shortage, can be mitigated by this educational event. And so we can use the resources that are already quite scarce for good use. I'm honored to be part, and I would like to thank all for organizing this discussion, this debate with such qualified professionals. And I think we will be certainly contribute to health in America, in Latin America, and fight these pandemics together. We're very happy because of that. So I hope you all take advantage of this, and you're more than welcome to make questions. You can all contribute so that we can all have a stronger Latin America and a better education in terms of how to use these tools and how to decide on these resources so that we can use them wisely because they're so scarce. So thank you so much and have a good day, everyone.
Muchísimas gracias, Rafa. Un gusto de verdad poder generar
Thank you so much, Doctor. Thank you, Rafael. It's wonderful to create a family with Brazil. It's such an important part of the territory and in the continent, of course. We love this brotherhood with world leaders. And we're very excited to have Dr. Gerlinger here and many other doctors that share this policy. And this policy is now telling Latin America, open the door for us. We urgently need access and try to save more lives in order to give an answer to all these issues and all these questions that, of course, come up in our daily practice. Right now, I would like to thank very especially our translation team.
Mi pantalla, espero que sí.
I hope you are now seeing my screen.
Listo, voy a ponerla en este momento.
Okay, so this is our translation team. I would like to welcome them into our team, Sara Garcia and Victoria Magariños. They are our key components in this event because they will be the bridges between the panel members and the audience. We have more than 400 spectators who are now very happy because all this effort means there's a great organization before. So today, we will talk about how to introduce a PBM program in your institutions, in your centers, how to make everyone fall in love with the topic. And in order to do that, we have invited Dr. Omar Alberto Travadero. He's a specialist in chemotherapy and immunohematology, and he's an academic professor in medicine at Austral University. He will talk about how to implement PBM programs, how to bring them from evidence to experience. Our second panel member will be Dr. Pedro Sebastián Ruiz, and he will talk from the province of Mendoza in Argentina. He is a specialist in immunohematology graduated from National University of Cordoba. He is the director of the Chemotherapy Regional Center in Mendoza. So he will talk about the general vision of PBM and how to develop a program at a local level. So the panelists can now activate their cameras if they would like. And Dr. Gerlinger, you are more than invited to activate your camera.
Muy bien. Antes de iniciar, quisiera...
Before starting, hi, Dr. Gerlinger. Nice to see you. Dr. Pedro, Omar. Just a short set of instructions to all the attendees. In your smartphones or your computers, you will find a world map in the lower right corner, and you can switch the language settings there. You can also disconnect the original audio so that everyone can be comfortable in case you would like not to listen to the translation. Please it's important that you will not be able to interact through voice or your cameras. This is just to offer a bit more order and organization to the session. But if you in the audience have any questions, you can contact your local representative, and we will try to solve these problems that sometimes come up in these online set of conferences. At the end, we will have a Q&A session. It will last around 20 minutes, so please write your questions through the attendees participants chat so that we can go through the questions and ask them to our panel members. So without further ado, I would like to welcome you and invite you into this idea that if knowledge is not put into practice, it does not benefit anyone.
¿Me escuchan?
Can you hear me? Yes, it's working. So to wrap up, I would like to invite you all to think about the idea that this knowledge that we will learn this Friday and all the following Fridays in the next few weeks, we should put it into practice and we should implement everything that will be discussed. That is the greatest gift that you can give us, implementing everything that will be discussed here. So without further ado, I would like to invite you all to start this first session, how to implement a patient blood management program. And so we begin our set of conferences with Dr. Omar Alberto Travadelo. Good afternoon, doctor. Great. Can I start sharing my screen then? Of course.
Bueno, muy buenas tardes a todos.
Good afternoon, everyone in Latin America.
Escuchando estas conferencias.
Everyone who's online right now. I would like to thank Werfen for trusting me to share my experience, our experience at Austral Hospital to implement a program, a PBM program that we believe has given us very interesting results, especially when it comes to patient care. So we will start with the idea of presenting. I apologize, I seem to be having some technical difficulties with the presentation. I cannot get the slide. I cannot get to the next slide. There we go. Wonderful. So we'll divide it in two parts, although we cannot extend a lot in this, but we'll try to define PBM. Sometimes when we focus on PBM, we see a baggage of methodologies, drugs, techniques, etc., that contribute to the ultimate goal, which is management, the use of blood components. This isn't really what we look for with PBM, though. What we want is to establish a program that will lead to a good use of blood components in a timely manner. And so when we decide to start a transfusion management program, we need to bear in mind some things that will help us order our methodology. First of all, we need a set of guidelines, a set of objectives. And these objectives need to be measurable. They should also be attainable objectives. They need to be realistic. They need to be within our reach. We shouldn't think about unrealistic objectives. Oh, Dr. Travadello seems to have muted his microphone. I am sure he will fix this shortly.
Doctor Travadello, ¿no le escuchamos?
He's just been informed. I am sure he will open his mic soon. There we go.
Para que lo ponga en pantalla completa porque estamos viendo la diapositiva que sigue.
Sí, ahora lo veo. Ahora sí. Bien. Sí, ¿de dónde no se escuchó?
Where did I leave off?
Hola.
Sí, en la segunda diapositiva, digamos.
In the second slide.
¿Aún no estamos viendo su pantalla?
A ver.
Ahora sí. Pantalla
That's
completa.
great. Share screen, doctor, please.
Ahora sí. Bien. Ahora.
Sí.
How about now?
Listo.
¿Se ve ahora?
Nice. Perfecto.
Ok, perfecto.
Wonderful.
¿De dónde estábamos aquí?
So where were we?
Sí.
Bien, perfecto. Entonces decíamos que la serie de conceptos que uno...
So this series of concepts that sometimes we pour to say, okay, I will implement a PBM program or a transfusion management involves many methodologies, techniques, evaluations, assessments, drugs, equipment, etc., that lead to the ultimate goal, which is using blood appropriately. But actually, when we want to implement a program, we need to set our objectives first. And these objectives need to be measurable, they need to be attainable, they have to be realistic, they need to happen within a time range where we can assess how that objective is happening. And we need to know that it won't happen overnight. But in order to have these objectives clear, we need to trace many strategies. And these strategies are very varied, such as education, information, communication, evidence, and evaluating the cost and benefits. So it's as if I wanted to take over a territory. I can have a single strategy or many strategies that can become combined for my ultimate goal. These strategies also require or call for tactics. In soccer, for example, we have different tactics. Sometimes you can make a goal to the other team from the corner, etc. So this is also what we need to have in mind when we're decided on leading this ultimate goal of a PBM program. Very well. So we have all these elements. How can we organize them? This is how we organize them. We have our goal here. We establish our strategies, the tactics that we will use to bring forth each of these strategies, and the instruments. The instruments should not be confused with the ultimate goal of PBM, because PBM is not the same as pre-blood donation or perioperative blood donation or other elements. This is a set of goals that we will evaluate and use for our arterial goal, which is the program, ultimately. So this quick introduction serves to show how we have conducted things in our hospital in this PBM program implementation. And they have taken us to instances where first we assessed what our territory was like, the place where we would develop our strengths, our weaknesses. This is a picture of what today would look like in our hospital. And of course, it's a very different picture from 10 years ago, or more than 10 years ago, when we decided to start the PBM journey. Back then, needs were different. Maybe they were minor needs, but they did help us to traverse this road and get to today far more easily. We said then that for a clear set of objectives, they need to be measurable. And every PBM program needs a command chart, a command board. And this should reflect what the real need is. What is the real use of our blood components? How many patients do we have? How many patients will be subjected to any intervention or to the need of having or receiving blood transfusions? And you can only get this information through this board so that we can follow over time the evolution of our patients or the indicators. Our program started somewhere around 2008 with the basic idea of knowing that we need to have control of the blood transfusions for our patients. Why? Because it's a good medical practice. It's good medical practice that they receive as little transfusion as possible. And we should bear in mind that many times blood transfusions are necessary, of course, because that's something that the life depends on. But we should always bear the ultimate cost benefit. We should always analyze this. And since then, over 10 years, we have been able to stabilize this, and now we have maintained this management, this adequate blood component management. This allowed us to reduce blood transfusions and improve patient outcome. Another idea that is very frequent when implementing PBM is that we need resources. But most of the times, we need to start a PBM program without resources, especially because in traditional medicine, we don't have as many resources as other areas in transfusional medicine. So we need to be creative. When we started our journey, the first thing we did was set the priority on pre-surgical patients. We noticed that in these patients, we could get in a short time the best results, the best outcomes. And this is when we implemented something that was useful, which is the pre-surgical interview. What does this entail? Well, detecting all of these reasons why the patient can be at risk of receiving unnecessary transfusion. So, of course, handling pre-surgical anemia is very important too. And here we moved from a stage where the surgeon ultimately decides what's the status of the patient, to define this from the pre-surgical stage. And this improved patient outcome a lot for us. It translated into better blood reserves, their own blood reserves, so that they could get to surgery. And we also got a better idea of what the causes might be that may lead to problems during surgery, ultimately preventing a major bleeding scenario. Secondly, we also established algorithms for transfusion. This is not major work. This is really just starting and getting down to work with other services, with other patient care services. We were lucky enough to receive support from the intensive care unit. And this team was also convinced that if somehow we could establish a better assessment of our patients and place or implement a different set of transfusion criteria, we could eventually prove that these patients could have equal evolution without the need of transfusions. That additionally might bring adverse effects. We implemented this with the intensive care unit department. We worked together, and in a very short time, in about 6 and 7 months, we proved that patients that were transfused according to this algorithm with a pre-transfusion trigger of a hemoglobin above 7 grams per deciliters in patients without additional pathologies in terms of cardiovascular or pulmonary scenarios. When these patients had these characteristics, we were able to reduce transfusions around 21%. Other solutions that may be available, totally free of costs, is consensus. In our hospitals, we do practice consensus, which means that several of us, several specialists, sit together at a table, for instance, from cardiovascular surgery that requires anesthesia, hematology people. All of them sit down and discuss things. There was a tendency back then in cardiovascular surgery to transfuse patients with plasma and platelets at the end of surgery, with the idea that that was going to improve, very importantly, patient hemostasis, and that it would bleed less in post-surgery. But actually, post-surgery, we ended up with patients with inflammation, with severe inflammation, which made recovery a lot harder. So we had to discuss based on evidence, and based on this, we were able to reduce our numbers of transfusions. We were also able to put this into practice for liver transplant, where we assessed cost-benefit analysis. We analyzed the recovery of all liver transplants, and we reduced 31% of red blood cell transfusions. And the chemotherapy staff service working jointly within the operating room was very important, so that we were able to reduce the use of fresh frozen plasma. Another improvement that, again, is quite free of cost at first is the possibility of inviting the patient to think of a request for transfusions. This is a guided transfusion request where if the doctor wants to transfuse, he or she should be able to fill out a form and justify why this transfusion is needed. And so in our practice, this made the doctors think twice, before transfusing. And this ultimately reduced red blood cell counts, red blood cell transfusions. Finally, one of the ways to arrive at a better understanding of the solution of patient bleeding can happen when we have this inconvenience of massive bleeding, where each of the actors, each of the participants, instead of defending patient situations, we try to defend our own needs. So the surgeon tries to prevent major bleeding in this operating room. The hematologist tries to order as many blood products as needed to reduce the bleeding, but actually, after based on this is based on subjective elements because laboratory values do not accurately reflect the degree of hemostatic compromise of the patient. And this is the source of all problems because each specialist analyzes it from their own perspective. So what we decided then was the possibility of having a much more objective resource to measure coagulability in the patient. And this is where thromboelastometry for us was very useful to assess and maintain the patient with an active bleeding and who might need a correction of this hemostasis condition. This substantially changed the scenario for us, and it allowed us to rest a little bit and to be calmer in the scenario because each of the professionals were able to focus on their area of expertise. And ultimately, we were able to reduce transfusions. So, to close this presentation, evidence is important. Evidence is one of the elements that we need to base our criteria on for any program. The three main pillars prove that when they are used in combination with one another, they improve very much the need for unnecessary transfusions. This is a study I mentioned because I think it's very important in recent times and with an interesting sample. In this study, the sample covered more than 100,000 patients in stage 3, and the study clearly concluded that red blood cells transfusions was reduced, and ultimately mortality and complications were also reduced, and this is very important. And in our perspective, experience has shown that through PBM programs, we can reduce red blood cells transfusions. So as you can see here, they are going down in this red line. Maybe not as much as other components, but there is a significant reductions. And we were able to reduce in the yellow line plasma transfusions through the use of thromboelastometry, because then we were able to show that this is not the best blood component, and we should only use it in a few number of cases. Additionally, this helped us see that hospital costs are very much reduced because we no longer need to resort to different blood products that are very expensive for any hospital, any center, anywhere in the world. Because blood, in order for it to be safe, requires great investment behind. So this is why we should use it very wisely, and we can also improve hospital costs as well as patient outcome. So as a summary, we need to reduce unnecessary transfusions. This will improve quality in our patient care. This will lead to better evolution. Of course, this also reduces costs. Reducing unnecessary transfusions reduces costs, as well as lengths of stay. They are shorter. There are less complications after surgery as well. And for those of us who work in chemotherapy, for those of us who need blood components, this helps us keep an adequate stock or reserve of blood products so that when we do need them, they're still available. So this is the end of my presentation. Thank you, Werfen, for the invitation. I hope I've been somewhat of use with my ideas. I look forward to your questions. Thank you.
Muchísimas gracias, doctor Omar Travadelo.
Thank you, Dr. Travadello.
Estamos muy felices por haberlo tenido en nuestra sesión.
We're very happy to have you featuring in our sessions. Please stay tuned for questions at the end of this session. Let us now welcome Dr. Pedro Ruiz. He's an internal medical doctor. He is the director of the Chemotherapy Regional Center in the province of Mendoza in Argentina. Thank you. Good afternoon, everyone. I've just started sharing my screen. Please let me know if you can see it properly. Yes, it's wonderful.
Bueno, sobre todo agradecerles
I would like to thank this opportunity, and I'm happy to get out of these negative data because of the pandemics. And I think it's a very good opportunity to share everything that's been positive, like sharing this now, sharing our experience from home where we can be calm and cozy and very comfortable. Besides sharing our experience in Mendoza, we want to share the experience we are creating as we create this PBM program. And I would like to share what have been our support points to implement this topic in the province. Then I will share some data in terms of transfusions in the province and this structure that we want to create. So as for the institutions where we support ourselves, we have WHO, the European Commission. In the UK, we have the NHS Blood and Transplant, and then other authorities such as National Blood Authority from Australia. And all of them share a priority, which is avoiding the overtransfusion and schedule surgical interventions in patients with in anemic patients with a bleeding risk. As for guidelines and consensus, there are several documents available that invite to the use of PBM. You can see here the Sevilla document, the Appropriateness Allogenic Red Blood Cell Transfusion International Consensus Conference. They also issued a paper. The Society for the Advancement of Blood Management also did a publication, and they all recommend implementing patient blood management in health organizations. I won't go over explaining the studies or the papers here. This is just to show what is our backbone in the making of this structure for the program. What is our rationale? This is a study that I very much like because it covers an entire sector of Western Australia, and our intention is to implement this program across the entire province of Mendoza. And you can see in the graphs here, very interestingly, that as the population increased in 2008, they started with PBM, and red blood transfusion started to decrease. There was a reduction in 28% hospital mortality, 10% of median hospital stay, 21% reduction in infections, 31% in myocardial infarction or stroke incidence, and the use of blood components was reduced in 41%. This translates into increased safety and effectiveness for the patients within a PBM program. This study here by a set of German clinics in perioperative settings. They analyze items such as hemoglobin optimization, alternative techniques for hemocomponents reserves, for saving hemocomponents, blood components, and you can see here all the activities that they were doing across each stages, preoperatively, intraoperatively, and postoperatively. And so while transfusions save, an excessive use of transfusions may be associated with short-term and long-term hazards. And we see that anemia, loss of blood, transfusions, they're all predictors of adverse effects, independent adverse effects in patients. We have also a series of recommendations for implementing these tools. For instance, we have here this checklist to implement PBM, and they cover simple measures to reduce anemia and transfusions. And we see here how this represents a new quality standard for patients. We have different PBM measures here divided in 6 blocks, 6 areas with 4 guiding principles, such as optimizing coagulation management and interdisciplinary quality, taking patient-centered measures. And these guidelines, they are very easy to access, the European guidelines for hospitals and health authorities. These guidelines highlight the importance of adopting PBM as a standard of care to improve patient safety and patient clinical outcomes. Based on what I just mentioned, in our province, 50% of transfusions are misindicated, and within a single intervention, depending on its nature, different blood components will be used. This results in increased hospital stays and costs, of course. And so, little by little, we began introducing this idea. We have called this a program for transfusion safety area. In order to implement this, this is the Kotter model, a methodology for changing management. We have 8 steps that we need to cover to implement the notion. We need to establish the urgency for PBM, then create a powerful group, a powerful leading group, create a vision of PBM, communicate our PBM vision to all the interested parties. We need to empower our team, create successful measures in the short term, build on change, and anchor PBM in the organizational culture. As from 2016, we began implementing these steps across a variety of activities, such as different seminars, in critical bleeding conferences, and slowly but surely we introduced the ROTEM system, which is like the gateway to interact with other services. And so we began proving that patients did actually do better without as many transfusions if we used the ROTEM system. We paved the way. We are still doing this, traversing this road. And last year, In this conference in the region of Cuyo, we devoted an entire day to talk about transfusion, a rational use of transfusions, and we also implemented a seminar workshop. This is where Dr. Gerlinger also joined us among our activities, and Dr. Villaseca from Buenos Aires. Our intention here was prove or show the authorities in hospitals and the ministries how we can work to establish this transfusion safety area program. I belong to the Regional Center for Hemotherapy, and our intention was to interact with the different hemotherapy centers. And so this is how we began working with these centers from hospitals Lago Maggiore and Central Hospital. The intensive therapy units at these hospitals have helped us a lot. They have participated very much. This safety zone seeks to offer a structure that offers training and a standard of care in the rational use of blood. We want to arrive at the proper measurements we need to improve. This is very important. And we want to implement this standard of care that guarantees quality and efficiency in the care that we offer, in this patient-centered care that ultimately also reduces costs and increases quality. As for the rationale, this is what we've discussed with authorities. We do cause damage to patients if there is untreated preoperative anemia. And so sometimes we also, one of the foundations is the poor proactive treatment of bleeding conditions or the high rates of transfusion across all institutions, limited resources. Transfusions are one of the most overused procedures in current medicine. There are many articles as far back as 2010, and these studies pinpoint the fact that transfusions are among the 5 most overused procedures. And so the entire medical community needs to work jointly to reduce this rate. A few data from our province. These are statistical data since we began to instill the idea of PBM in the province of Mendoza. In 2016, 2017, the number of extractions were the same, between 23 and 27% of volunteering donors in the province. In 2017, or 2018, the blood extraction number was increased, then we have greater blood components, and then in 2019, now that we have this firmer structure at this time, we have made it to a 41.9 volunteer donors. Our goal for 2019 was to attain 100% volunteering donors. We still have a long way to go in that sense. But over time, we can see how we're optimizing time, how we're reducing unnecessary transfusions. And we see an increase in the units transfused. If you look at here, 2016, 2017, 2018, the peak was above 29,000 transfusions, and this was reduced in 2019 with almost 24,500. I also mentioned that we began this work with institutions such as Lago Maggiore Hospital which is like the main unit in terms of maternal care and trauma.
Y donde vemos que
We see in blue Central Hospital, the number of transfusions among these hospitals, Central, Noti, and Lago Maggiore. Central Hospital represents around 50% of all the interventions. You can see an increase in transfusions, but in 2019, in the two institutions where we were able to create a joint activity among the services, we succeeded in reducing transfusions so we got 7,297 transfusions in Central Hospital and 3,967 in Lago Maggiore. But in Noti Hospital, where they only work with safe blood. So we decided to start working with these two institutions, with the anesthesiologists and other specialists. We focused on adult patients. We made some improvements in these activities in the adult sector, and then our intention was to move to the pediatric population. And here I would like to show some information on the rates. You can see how we began in 2016, how we moved on from 2018, and Hospital Central in blue and in yellow, Lago Maggiore Hospital, they reduce the rates and indexes for transfusion. I said then that data is very important to continue improving. Even we have found it hard to have a clear idea of the number of patients that have been transfused in 2016. And then in that year, we realized that we needed to be more strict in terms of statistical collection of data. Over time, we saw that patients increased, but in 2019, they began to reduce, the curve started to go down. Also, the transfusion rates and transfusion indexes were reduced. So this is part of the data that we started collecting. And then the next step is to connect this to average hospital stay, to mortality rates, and infection rates. We also conducted a cost analysis to show the authorities that implementing this program could entail saving costs. Of course, this wasn't a truly financial cost analysis. It was just to prove a point. We should bear in mind that the total transfusion in milliliters at that point was calculated at around 5 Argentine pesos. The dollar exchange rate at that time was around 20 pesos for $1, an American dollar. So implementing this transfusion safety area program, where we can have a 30% saving margin, based on this information, we could say that we could save up to $1 million if we compare them to the 17 million Argentine pesos. So implementing a multidisciplinary approach for the hematopoietic system for each of our patients is absolutely important. This is an activity from all the stakeholders, all the participants in a medical institution. And we work on 3 pillars of PBM: optimizing blood volume, a perioperative diagnosis and correcting anemias. Then the second pillar is reducing bleeding, improving techniques of anesthesia, among others, which this is like the access door. And this is where we can interact better with other medical specialties. And finally, we need to improve the tolerance to anemia in this restricting behavior of transfusions. This is connected with the bibliography already shared. As for the infrastructure of this transfusion safety area, we need to create a formal organization chart with all the duties and responsibilities for each of them. There should also be a committee. And I would like to share how this should maintain itself over time. We discussed this with the different authorities. We wanted to discuss with them the fact that this should not just be a mere activity, a mere program. So we decided that these people who were involved in this structure, in this infrastructure, should be released 4 hours in the week, so they were free from conducting surgery or other obligations. And all of us then should take care of building this organization, the guidelines, and different activities and tools that we will implement in terms of PBM. The hospital directorates are very important. The clinical departments, surgical clinical departments, they have all helped in intensive care units mainly. We need to ensure continuity and the sustainability of this program. The participants should also be involved in the transfusional service restructuration, reorganization. This is for the sake of transfusion safety. We don't want the hemotherapy center to be like a pharmacy that offers blood components. The idea is that we interact and we promote a change in paradigm, either in the hemotherapy services or in how this is implemented. This is part of a multidisciplinary work, so we need to make sure that there's ongoing training, ongoing education, implementing initiatives, and offering the right tools to the heads of all these medical institutions so that they can evaluate the measures and the numbers that are happening. Another key aspect, of course, is patients and offering a voice, giving the patients a voice, and publicly discuss the need for PBM. As for actions, we need to establish an internal ongoing report system, as well as a comparative evaluation system with different stages. We need to, in stage 1, measure the transfusion rate and the transfusion index. On stage 2, we need to collect data from the patient about anemia and its treatment. On stage 3, we need to collect data on the loss of blood, calculated perioperative loss of blood. And finally, in stage 4, we need to measure all the data that will be useful for the patient. So to conclude, carefully managing blood translates into a significant reduction in the use of blood products and improves patient evolution. PBM programs decreases costs and increases quality of care for patients. Implementing a patient-centered approach that is multidisciplinary and includes the entire staff of all the services is also very beneficial. This is the journey. This has been our experience so far. It has many curves. It's not a straight line, but we find the challenges very interesting. I hope you have found this information useful. Thank you for the time. Thank you, Dr. Riz, for your wonderful contribution. I agree that this is a journey that we're still walking on, and we are preparing the road so that many others can come and follow. I would like to make a few announcements. For those of you who would like to see the interventions again, we will record this on our YouTube channel, on WRFM LATAM YouTube channel. These recordings will be available for those of you who go to the channel. You will be able to see them as many times as you like. Now I would like to welcome our co-chairman, Dr. Klaus Gerlinger. Welcome. It's a pleasure to have you here.
Thank you.
And we're eager to listen to you.
Yeah, I just take over the screen. So I hope you can see the slides.
Not yet.
Yeah, so the topic I'm talking about is, of course, also about the concept and implementation of patient blood management, and I will show a little bit the background on and the evidence. My personal history is that I'm by education an anesthesiologist in emergency and intensive care medicine, working at the University of Hospital of Essen in Germany for 26 years. And about 20 years ago, we started, it was not called at that time patient blood management, but we were rethinking what's the best way in dealing with patients with quite a high blood loss. And that was when I was at the time dealing with liver transplants. So from my point of view, the story of PBM is a story of changing minds, which is a big opportunity, but it's also a big challenge. And going back 20 years, it was for me the same. You were thinking as a hero if you could manage a massive transfusion. And now you are a hero if you can avoid massive transfusion. So I think this is a change in mind. And as mentioned already, a ROTEM-guided bleeding management is an important part of patient blood management, but we just don't do it just for itself. Again, it's a part of patient blood management, and patient blood management, we have to understand, is an important part of patient safety. So that's, in the end, it's also not about just reducing the amount of transfusion. It's about yes.
I'm sorry to interrupt. We cannot see your screen for some reason.
Okay. Just have to see what I have to do. Can you see it now?
Not yet.
Not yet.
Not yet.
Not yet.
I'm just pushing the button, sharing the screen. Now?
Yes.
Yes.
So.
Okay.
Yes.
Sorry for that. Just go into presentation mode. Yeah, just go one slide back. So again, it's not about just doing a ROTEM. This doesn't really help, just doing a diagnostic. Again, it's a part of patient blood management, and it's an important part of patient safety. And this is not an idea from the last 10 years. It's an idea already 2,500 years old. It's more or less coming from Hippocrates in Greece. And, you know, of course, we all want to cure. But even more important first is to avoid additional harm. So we really have to think about and maybe do a step back. Is all the blood transfusion we do, is that really appropriate and beneficial for the patient? It might be even sometimes harmful. And that's the idea of patient blood management, because it's a timely application of evidence-based medical and surgical concepts. And what is the target? The target is to maintain the hemoglobin level with the patient's own blood, optimize hemostasis, minimize blood loss, and again, improve patient's outcome. So this is always finally the aim. It's nice to save blood, in particular in times where blood donation is going down in the time of pandemia. But again, the aim is to improve patient's outcome. And you see here, these are different presentation of the 3 pillars. Here we have 4 parts. So of course, managing anemia is an important part. An interdisciplinary blood conservation modalities. Coagulation is more and more recognized, because if there's coagulopathic bleeding, of course, we have an issue and that the patient loses more and more blood, and the patient is in the center of decision making. So again, improving patient's outcome is most important. We have seen already the 3 pillars, and even within PBM, we have something like a change in mind, because in the first years, everything was focused on anemia management and red blood cell transfusion. And everybody was just looking how we get red blood cell transfusion down. In between, we learned, and we'll show you a couple of publications, that it's not only the red blood cells which might be harmful, maybe even the yellow blood products like plasma and platelets might even be more harmful in some situations than red blood cells. So that also means that there is a shift from the first pillar, that we more and more also focus on the second pillar, which means minimizing bleeding and blood loss. And also my presentation will focus on this second pillar, but of course also the third pillar is important to optimize physiologic tolerance of anemia. So what is the main issue? Some years ago, we just thinking, okay, if the patient is bleeding, we just have to replace blood, that's it. But more and more, we have publications showing that inappropriate blood transfusion increases morbidity, mortality, and also, as we heard in the last presentation, healthcare costs. And of course, there is a dose-dependent effect, which means here in this study, and it's nearly 1 million patients from the US and Canada, we see there's a dose-dependent effect of transfusion on 30-day postoperative mortality. So if there's no transfusion, it's only about 1.2% mortality. Already with 1 to 4 units, it goes up to nearly 9%. And with massive transfusion, here defined as 5 or more units of red blood cells, it's again increased to more than 20%. So there's a close relationship between the amount of transfusion and outcome. So again, we are looking at patient safety. And one of the most important lessons I also learned was less can be more. So it's not good to give as much as blood to the patient. It's good to give enough blood to the patient, but not more. And this is a part of the patient safety movement and also PBM in the European Society of Anesthesiology and worldwide in the movement of patient blood management. The next issue for me is that I call this an evidence-belief mismatch or a risk awareness deficit. What does that mean? That means, of course, everybody tries to treat the patient in the best way possible. But, and therefore I'm coming back to the mind shift or change in mind, is that we learned that what we did in the past might not be always the best way to treat patients. And this is just a survey. It's from the group from Simon Stanworth from Oxford in the UK. And he was sending a survey around to pediatric ICU units 2 years ago or 3 years ago, and just was asking what they think about blood transfusion. And in particular here about plasma transfusion. And 43% of all respondents believed that plasma transfusion can arrest bleeding. And even 27%, so nearly 1/3, believed that plasma transfusion can prevent bleeding. And if you think like this results that they use it even quite liberal for hypovolemia and even for mildly abnormal coagulation tests, and think that this is an appropriate way to treat patients. But we heard already also in the last presentation, when we look at the data here from the National Summit of overuse, and this is from 2012, so it's not really new data, that blood transfusion is the ranked second overuse treatment, at least in the US, but I think around the world. So we give much more blood transfusion than it's really needed or beneficial for the patients. So what does really the evidence telling us? And of course, when we look at evidence, the highest level of evidence always randomized trials or even meta-analysis from randomized trials. And this is a Cochrane analysis looking at plasma transfusion in cardiac surgery. And this is based on 15 randomized trials, including more than 750 patients. And interestingly, here, transfusion of fresh frozen plasma was inferior to placebo. So usually I think we do things which have a benefit, but not which is inferior. The only reproducible thing was that plasma transfusion increased red blood cell transfusion with an odds ratio of 2.5. So we have more red blood cell transfusion if we give plasma, and not that we decrease red blood cell transfusion, what we would expect. So the reason for this might be that the only reproducible effect of plasma transfusion is that we dilute the hemoglobin level. So that means giving plasma reduce the hemoglobin level. This triggers again the red blood cell transfusion. And if you use a transfusion protocol like a ratio-based approach, if it's 1:1:1 or 1:1:2, this just means, again, you give also more plasma. So we come in a circle of more and more blood transfusion. But when we look at registries like the UK short report, serious hazards of transfusion, and also data from the US FDA, we see that nowadays the most important issues which can result in transfusion-related mortality are three different points. One is transfusion-related acute lung injury. The second is transfusion-associated circulatory overload and transfusion-related immunomodulation with an increased risk of microbial infection. So these three are responsible for 2/3 of all transfusion-related mortality. And when we look here again in the patient population here, even of critical ill children, we see that this happens much more often than usually expected. So in this study, they see in nearly 7% of all critical ill patients or critical ill children that they develop a transfusion-related acute lung injury. So these critical ill children have a much higher risk of TRALI if they are on mechanical ventilation, if there are severe infections, and this increases mortality significantly. Also, the second issue, transfusion-associated circulatory overload, was much more often, but it depends on the diagnosis. So what is really a volume overload? So dependent on the diagnosis, it happened between 1.5 and 76% of all critical ill patients in a pediatric ICU again. So again, it's much more often, but it needs the awareness that you look at it, because also from my point of view, 20 years ago, when we give a massive transfusion, we thought it's normal that the patient have a bad lung function, have also cardiac issues. But by changing your mind and by being more restrictive in transfusion, in particular also in plasma transfusion, we can avoid a lot of these complications. And the third aspect, as we were looking at the statistics from the short report, this was nosocomial infection. You see here again, besides multiple organ dysfunction, which increases threefold with patients who get plasma transfusion, also nosocomial infection rate is getting up. What's about platelets? Platelets, of course, are important and major players in hemostasis, but they're also major players in inflammation. And you know, it was already mentioned from one of the speakers before that inflammation is an important issue in the postoperative period. When we're looking here again at pediatric ICUs, you see that 2/3 of all platelet transfusion is done prophylactically. And even in patients with more than 20,000 platelets per microliter, and only 1/3 is giving therapeutically. So we have to think about if really this prophylaxis has any benefits. And this was also assessed from the group from Daryl Kaur. It's from Mayo Clinic, Rochester in the US. It is not a randomized trial, but it's a big cohort study with 40,000 patients were treated with platelet transfusion, prophylactic platelet transfusion, when they were critically ill. And there was no benefit, but there was a significant increase in multiple organ failure and also in the length of stay at ICU. So when we look at very specific settings where at the first view, it might be reasonable to give platelets. So here in this study, they looked at platelet transfusion in patients with gastrointestinal bleeding, in patients taking antiplatelet drugs. So the first idea is, yeah, maybe it's a good idea to give platelets. But the risk of death increased 5.6 times. And even the adjusted odds ratio for rebleeding was not decreased, it was increased by 47%. So the use of platelet transfusion, just because there is GI bleeding and the patient are on antiplatelet drugs, seems not to be a really good idea. Going to another setting, it's platelet transfusion in traumatic brain injury. And of course, if you think about, okay, this patient has a severe trauma and he might even bleed in the brain. So it might be beneficial to give platelet transfusion to these patients. But if you look at the meta-analysis of these studies, you see that platelet transfusion was associated with a 50% increase in mortality. So again, not any proven benefit, but increased risk of mortality. And now we just move for the last papers to really high-ranked papers. So this is a randomized trial published in Lancet. So one of the most recognized papers in medicine in the world. And here again, they were looking at patients with acute hemorrhagic stroke on antiplatelet drugs. And the question was, if we randomize these patients to platelet transfusion or no platelet transfusion, is there any benefit? But again, there was no benefit. There was an increase in mortality 2 times. So that was the reason that also the editors of this paper came to the conclusion that platelet transfusion seems to be inferior to the standard of care after acute interstitial hemorrhage in people taking antiplatelet therapy. That doesn't mean that we should not give platelets at all, but we should think again if this is really appropriate and if we have the possibility to measure. So we can use viscoelastic testing like the ROTEM to see what is the clot firmness, and we can even also do point of care platelet function testing if even these patients with antiplatelet therapy have a platelet dysfunction, because we know that at least 25% of all patients on antiplatelet drugs are non-responders. So then there is no need to replace platelets. And the last study I want to show you, it's again a randomized study about platelet transfusion in neonates. And it's published in the New England Journal of Medicine, so the second really most recognized medical journal in the world. And what they did, was in neonates with thrombocytopenia randomized if they give platelets already in a liberal way when the platelet count was below 50,000, or if in a more restrictive way, only if platelet count was below 25,000 per microliter. And interestingly, in the more liberal approach, the mortality was 1.6 times higher. So again, also here in the editorial, they come to the conclusion, not less can be more, less is more. So again, we should think again when we have patients, in particular, when it's just about treating numbers. So is there an increased INR with a low platelet count, but in the absence of bleeding? I'm quite sure being more restrictive is more beneficial. But even in case of bleeding, we have really to check what is the reason for bleeding. So just to summarize the first part, so transfusion itself doesn't stop bleeding. It gets us time to fix a problem. But the treatment of bleeding is to stop the bleeding and not just to transfuse. And that's true in trauma and in major surgery and also in a lot of other areas. So again, we need a mind shift. And this is a paper published 3 years ago, also in Lancet. And that was corresponding to the European Center TBI study, a big study about traumatic brain injury. And here the authors come to the conclusion that the one-size-fits-all management, like a ratio-based transfusion approach, just giving 1 unit of red blood cells, 1 unit of plasma, and 1 unit of platelets, is very unlikely to be optimum in all individual patients. So what we need is, as it's called, precision medicine. That's coming from oncology, but it's also what we're doing every day in anesthesia and intensive care. We don't give every patient the same volume, the same inotropes or catecholamines. We also, of course, adjust the ventilation. So that means precision medicine means we first have to do a diagnosis, and then we can do a targeted treatment, and then we have a high chance to improve outcome. This is also from the same group and from a consensus meeting, and we heard in the first presentation that besides communication, consensus is a very important thing in patient blood management. And the next step, of course, is evidence and implementation and check effectiveness. So in this consensus meeting, we were just sitting together with people around the world who are experts in treating trauma patients. What might be the best approach if we do a goal-directed therapy? And we don't go into details today because we will do these on the next Fridays, but it just shows that by combining tests, here tests from ROTEM, the XTEM and FIPTEM, we can decide with a specific cut-off values when the patient will benefit, for example, from giving fibrinogen. When does he benefit from increased thrombin generation or by platelet transfusion? Yes, of course, there are patients who benefit from platelet transfusion. That we have to detect patients with hyperthrombolysis, but even more important is the last one here. This is a patient with hypercoagulability. So this patient is at risk of thrombosis. So to give blood products might even increase the risk of thrombosis. And coming back to the times of COVID-19, this is the most often seen thermogram in patients with COVID-19 because these patients suffer from hypercoagulability and the high risk of thrombosis. And we can use also viscoelastic testing more and more to identify these patients and avoid an overtreatment. So the concept of a ROTEM-guided patient blood management is just to administer the right hemostatic drug or intervention in the right dose, at the right time, and in the right sequence, and not throwing everything on the patient if there is significant bleeding. What we also have to learn is that we are talking in ROTEM-guided PBM about a negative predictive value and not a positive predictive value. What does that mean? We know from standard coagulation tests, you can have on the day before surgery pathologic results, but the chance that the patient is bleeding is quite low. Because even if you have a pathologic INR or low platelet count, the chance is only between 15 and 25% that the patient is bleeding. The other way around, if the patient is bleeding and we do viscoelastic testing like ROTEM, we can identify if this is the reason for bleeding, and the negative predictive value, which can exclude reasons for bleeding, is 90 to 95%. So as an example, if the FibTem, it's a test who looks at fibrin polymerization, is high enough, like in trauma higher than 12, more fibrinogen substitution will not be beneficial to the patient. So that means that the concept of a ROTEM-guided algorithm is a not to do protocol. So that means the first question always is there any significant bleeding? And then step by step in the protocol, we exclude reasons for bleeding. And these protocols, these are a review paper I did with some colleagues, also here from Mexico, but also from Spain and Korea, that we summarized the actual available evidence for producing algorithms in different settings. And you see this one for cardiovascular, one for liver and abdominal surgery, trauma and orthopedics, and obstetrics and postpartum hemorrhage. On the left side of the protocol is only what you measure with the ROTEM analysis, and then on the right side is the corresponding therapy. Why are we using such a checklist, like a flight checklist? In a real severe bleeding situation, there's not a lot of time for discussion. So then we need a strict protocol which helps even the non-hemostasis expert to do the right decision in a quite short time. So what's the evidence for implementing PBM or perioperative bleeding management? There has been even in 2016 an update of the Cochrane analysis about the meta-analysis and systematic review about the effect of viscoelastic testing in perioperative bleeding on outcome. But there's even a new update, it's just from this year, and it's done in Brazil. So of course it doesn't not only consider studies from Brazil, so it's just performed from colleagues in Brazil. And you see that the number of studies included even increased again from 2016. So what we see, there's a quite interesting new study from 2016, one of the first randomized studies in trauma done here with tech. And we have a quite long list of studies done with ROTEM between 2010 and 2020. And you see here from this diamond that already based on the ROTEM studies, there is a risk reduction for mortality of 0.48, so it means 52% less mortality. And even if we take together the tech and ROTEM studies, effect size is a little bit lower, it's 0.64, so that means 46% reduction in mortality. But this is also associated with a significant change, so p-value is 0.03. But it's not only mortality. Also, when we look at the incidence of thromboembolic events, it's quite interesting that even both viscoelastic testing systems are not working in the same way. So again, if we look at the tech studies, we have a slightly not significant increase in thromboembolic events. The reason for that might be that tech protocols usually are supporting transfusion of plasma and platelets. On the other hand, ROTEM protocols move away from allogenic blood products like plasma and platelets and are more moving to factor concentrates and a very specific therapy. And you see here the trend for thrombosis, in particular in the study here from Christian Weber, was just going to the opposite way. If we take both together, we can just say, okay, there's not a significant change in thrombosis, but as shown in the slide before, a significant reduction in mortality. There's another, I think, very important outcome, and this is acute kidney injury. So again, when we see at the TEC studies, there is a slightly decrease in acute kidney injury. When the ROTEM studies are already just with ROTEM, a significant reduction in acute kidney injury by about 50%. And even again, if we take this together, the TEC and ROTEM studies, there is still a nearly 50% reduction. And this is highly significant with a p-value of 0.005. So why is acute kidney injury an important clinical endpoint? It's important because acute kidney injury has a big impact on long-term outcome. So not a lot of studies are looking at 10 years mortality or even 5 years mortality. But this is from cardiac surgery, and you see if there is, that's the blue line, if there is no acute kidney injury after cardiac surgery, there's more than 90% 5-year survival in this cardiac surgery patient population. But if there is acute kidney injury, then there is only a 70% 5-year survival in this patient population. So that means if we don't avoid acute kidney injury after cardiac surgery, this increases 5-year mortality by 20%. So that means besides the acute reduction of mortality, there will be even a further reduction of mortality when we look at long-term outcome. Now we're looking in the last slides on overall patient blood management. And there has been a German study which included about 130,000 patients in 4 major university hospitals. And again, you see that also in these overall patient blood management studies, there was a significant reduction in acute renal failure in the patient blood management cohort, and at the same time, some reduction of red blood cell transfusion. But again, for patient outcome, I think the avoidance of acute renal failure is much more important. Of course, also in Australia, one of the key countries of patient blood management, a PBM study has been done and published in Transfusion in 2017. It was even bigger because it was over several years. It was 600,000 patients. And what was shown, again, there was a decrease in transfusion of red blood cell, plasma, and platelets by 41%, which again is nice, but this is not the aim of patient blood management. There was also a reduction in blood product acquisition costs, $18 million over 6 years. But this was even higher when we have to think about activity-based costs. So it's not sufficient just to buy the blood products. You have to transfuse this, you have to take care of the patient, you might have to treat complications. And we see here that also the incidence of complications like hospital-acquired infections was reduced by the factor of 0.8, so 20% less. Acute myocardial infarction and stroke was reduced by about 30%. Also, risk-adjusted reduction in hospital mortality has an odds ratio of 0.7, and length of hospital stay was reduced too. So it was overall, I think, a win-win. Less transfusion, less costs, and most important, less complications for the patients. Also, we did 2 years ago and presented this at the German Health Economics Congress, which usually looks at oncology because, you know, treatment costs for oncology is going up and up and up. And we were presenting data. What is the effect of implementing a thromboelastometry-guided patient blood management program on cost savings, on the one hand, for blood product acquisition, but on the other hand, and maybe more important, for potential preventable hospital-acquired complications. And you see, we took here these studies together and in a systematic review, and it's about 750,000 patients. And when we look just at blood product acquisition costs per 1,000 patients, that was a saving of nearly $1 million. But you see also from the economic point of view, to reduce potential preventable complications. This is about acute lung injury, acute kidney injury, nosocomial infection rates, sepsis, myocardial infarction. Again, the cost reduction per 1,000 patients is 1.8 million. So taking this together, the cost savings for product acquisition as well as complications, we talk about $2.7 million per 1,000 patients. So again, I think implementing PBM has as a side effect also the potential of decreasing hospital costs. But I think most important, it's not so good just to pick cherries within patient blood management. Only take care for anemia, only take care for bleeding. So of course, most effective are studies or projects which take into account the whole concept of PBM. So that means taking care for anemia, but also reduce blood loss and also take care for the patients later on at the ICU. There was one study, it was already mentioned already, from Frederica Althoff, who did also a systematic review and meta-analysis. And in this study published in 2019, she only considered studies which at least take care for 1 or 2 measures per pillar of patient blood management. So here we're talking about bundles of patient blood management, not just one single intervention. Of course, in the first pillar, again, preoperative anemia management is very important and one of the key points of the first pillar. Then the strategies to reduce blood loss and bleeding. And one part of it is, of course, using antiphobolytics, using cell saving, using hemostasis management based off point of care. These are important parts of the second pillar. And of course, also in the third pillar, a restrictive blood transfusion practice and tolerance to anemia. So again, combining this to a bundle of PBM, I think is the most effective way to manage PBM. And again, also this study shows cost savings is different from study to study, if it's in Japanese yen or US dollars or euro. All of these studies showed a significant reduction in costs. But again, in addition to the cost savings, the successful implementation of PBM was associated with a significant reduction in complication rates and mortality. And I think this is where we have to focus on. Again, it's nice to save blood products, it's nice to save money, but the most important thing is improving patient outcome. And I think actually in the situation of COVID-19, I think this is a good example that patient outcome is most important, because we all know is that shutting down our economics costs money. But finally, it's about the patients. And also this study, if we look at the table which summarizes the results, again, it's nice to have nearly 40% less blood transfusion. But key is again the reduction in major complication rates by 20%. And is again, you see acute renal failure by 26%, infection rate by nearly 10%, thromboembolic events by 25%, and overall mortality by 11%. So this is the key and this is the aim. And this is also what Donat Spahn from Zurich summarizes when he says patient blood management, what else? So of course, in addition, it's the introduction of patient blood management. We cannot implement everything at the same time. But we should also not say, okay, I take care for anemia management, that's it. So he defines in this editorial 7 key measures of patient blood management. And again, it's preoperative anemia, blood-sparing surgical technique, use of cell salvage and antipholytics, but also implement a goal-directed coagulation management, which includes monitoring, like point-of-care testing, and the use of coagulation factor concentrates. Of course, also post-operatively, we have to take care for anemia, and always we have to think about restrictive transfusion triggers, and this does not only apply for red blood cells. This is as important for plasma and platelet transfusion. So I think, again, we started with a mind shift, and we have here also a mind shift. So 10 years ago, the main message was donate blood saves life. Now the main message is save blood saves life. So again, less can be more. And it saves precious resources, in particular in times where blood donation is down and not at the same level as before. But it also saves money, and most important, again, it saves lives. And thank you for your attention, and open for questions and discussion.
Muchísimas gracias, doctor.
Thank you, Dr. Gerlinger, for your wonderful presentation. Right now, I would like all the panel members to turn on their cameras. We will start the Q&A session. I have the first question for Dr. Travadello. So, Dr. Travadello, you have a question. There's a question for you. Dr. Deirella asked if the measures for implementing PBM were done through consensus and protocols, and who are the ones that indicate who mandate the blood components in your institutions? How did you get them to, how did you get these protocols to adhere to the objectives in your program, Dr. Travadello? Most of the changes you saw there were consensus arrived at from surgical teams and multidisciplinary teams that participated across different specialties in patient care. With respect to transfusions, well, the decision is basically made from the doctor in charge of the patient. But blood transfusions not only can, but have to be audited by the blood transfusion doctor. This is not just an institutional decision, but this is also a legal requirement. The blood law regulates the use of blood components, says that the ultimate decision in terms of the quality of the need, the actual need of the patient, has to be done by the doctor attending the patient. So, of course, there's consensus, and this consensus is the product of transfusion guidelines in our country. These guidelines discuss issues such as transfusion triggers and other series of criteria to arrive at a decision. And this is what we rule ourselves by. But we do not refer to the fact that the transfusion doctor establishes a numerical value for a transfusion, but this doctor also becomes involved in the clinical state of the patient. And this is ultimately what actually validates the decision for a transfusion. The need for transfusion is validated, should be validated by the clinical status. And I think that's what should be prioritized. Thank you, Dr. Travadello. For Dr. Reese, when implementing your clinic on anemia, did you do this as a separate service, or was this ascribed to a specialty? Yes, we did this in the company of hematology department. The main fields involved are intensive care, anesthesia,
de anemia,
and this clinic of anemia that is now being developed in the company of the hematology department. They are the first ones to intervene in the pre-operative evaluation of the patient.
en las indicaciones,
We saw these improvements in the indications over time, that the intraoperative indication was appropriate, especially in 2019. We noticed this. Observing these patients and take a look at their medical record, we found many cases of anemia, and that's our main concern, really, in the two hospitals where we work with, the Central Hospital and Lago Maggiore. So Dr. Reese and Travadello, other questions? The ROTEM equipments that you used, where are they? Are they in hallways, in the laboratory, or someplace else? In our hospital, the equipment is in the transfusion medicine area. This was a strategic decision that we discussed with the different groups and teams in the hospital. We decided this because this area, the chemotherapy, is the first one that will hear of a bleeding in a patient. And so this meant a faster response to these needs. And from that moment on, this service has become the focus of all the samples and everything. But this is always connected with the other areas that may require the service. So visualizing the results and the outcomes is something shared. This helped us establish a language in common. We see exactly the same thing and discuss the same parameters. Because if we discuss, for instance, APTT, we may have different interpretations. However, if you have a thromboelastometry, it's very hard not to agree on what you are seeing and what the patient needs are. So this avoided plenty of discussion, especially in the surgery, in the operating room, because sometimes it's hard to assess the patient needs from an area or from two different areas. But ROTEM opens this possibility. It lets you show whether a patient does have or does not have a coagulation problem and arrive at appropriate decision. Dr. Reese, anything you'd like to share? In Mendoza, yes, in our case, ROTEMs are placed in the chemotherapy areas. And as I mentioned in my presentation, this equipment was the gateway to connect with the other specialties. In this journey, there are many challenges ahead. For example, the fact that the interpretation of the results should not be limited to a single person. We want to inform all the anesthesiologists and all the intensivists and doctors. We need to inform them about the results because they should not be decided alone by the transfusional doctor. These are cultural changes that need to start happening, and we need to move forward in this direction. Dr. Gerlinger.
Yeah, we have a little bit different history. When we started 22 years ago with ROTEM, it was starting a liver transplant. So it means it was initiated by the anesthesiologist and later on the ICU team. But I completely agree. I think it's very important to have a multidisciplinary approach, and discussing, for example, protocols in the transfusion committee or later on the patient blood management committee was very important. But since I was working in in a hospital with decentralized operation theaters who had different building, transport ways were quite long. So this would result in a significant delay that the measurement was started. And nowadays, since we have actually in the hospital 15 ROTEM devices, because it's used in all areas where there might be bleeding, I think even the lab or the transfusion department would be overwhelmed taking care at the same time, maybe for 10 different ROTEM analyzes. So that even resulted that even in the night time, where maybe in the lab is just there are 2 technicians, when we do it decentralized, it can be done still with a very short turnaround time. The other effect is, of course, you have to train a lot of people. So that was a lot of education. Nowadays, 70 people in the hospital are able to run it. But it has also a positive effect because there was a lot of education. So that means to me, there is not one single best solution. It really has to discuss in each institution, what is the best way to implement it and let it run. And as mentioned in the first presentation, we always have to check if we implement something, is it running in the best way? So for me, for example, to check turnaround times is very important because, of course, if it's done in the lab, maybe the quality of the analyze is higher, but it must be clear that the turnaround time is still between maybe 15 to 20 minutes, that the results are available for the clinician. Because if it's available after 1 hour, and if the perfect results, still then a decision has to be made before the results are available. So I think this is a lot of communication, and during the years of implementation, I think this communication was very important. And even clinicians and lab and transfusion department was knowing each other much better. So if there was any issue, this issue could be fixed much quicker than years before by a short communication. And the other point was to implement these algorithms just means that I think and we even checked this in studies, in 95%, just using a simple protocol comes to a right decision. There should be always somebody in the background. If there is an issue after 2 rounds, bleeding could not be stopped, that you can ask as the decision at the physician on duty, have somebody in the background with more experience that you can ask. But I think really implement simple protocols for quick decision is also a key, because it's not when the ROTEM is done, the patient stops to bleed. When the intervention is done, the patient might stop the bleed. So I think this is also very important.
Muchas gracias, Dr. Gerlinger.
Thank you, Dr. Gerlinger. I would like to ask one question and to wrap up this section for our 3 panel members. And this is about implementing these programs, PBM programs, in pediatric population. Sometimes children are the orphans of research, and many things become extrapolated from adult studies. So what is the impact, or in your experience, in terms of impact in outcomes for pediatric population, based on what Dr. Gerlinger showed? Any special experience to all 3 doctors? In our hospital, we agree on how pediatric population is the most complicated one, because you can't do many comparative results tests because of the sensitivity of this population. And the pediatrician is quite jealous, protective of these patients. So we know that bleeding has a greater impact, and the smaller the patient, the younger, the greater the impact. Some of our experiences have been useful, for instance, in cardiovascular surgery, using thromboelastometry improved a lot the capacity to reduce unnecessary transfusion in these patients, mainly platelets and plasma, when they were used without a proper checkup or control. The issue here is waiting for the result in order to take some action. And once the result comes in, you've already acted, and this changes the scenario. But this thromboelastometry really allowed us to have faster results and make timely decisions about much more sensitive items that the patients may need. For instance, we realized that patients don't need as much factors as fibrinogen. So the more fibrinogen you put to these patients, the better. We even separated in cardiovascular surgery two populations, those under a year and those above a year. Those in under a year, we do not even wait for a ROTEM to act. As soon as they start bleeding in post-surgery, or we act by giving fibrinogen because their age justifies this decision. It's not a rush decision, it's just a matter of offering something good for them. And we've also seen that these patients then bleed less in the post-operative session. And these are very delicate patients. They have very small reserves, and it's very difficult to move them out once they start massive bleeding. In our experience, I'm not a pediatrician. I don't have much knowledge on pediatrics. But what we should do in this structure is definitely to incorporate people from the pediatric unit once we have a broader and more traversed way, once we have covered more ground. Dr. Gerlinger, anything that you would like to recommend?
Yeah, so my main experience is again from the pediatric liver transplant area and other abdominal surgery. Also was working with our pediatric ICU. And of course, as mentioned before, of course, the blood volume of a neonate or an infant is very small. So already a minor blood loss, what we consider as an adult, induces big changes in the pediatric population. And that is, and as I heard from the other speakers, of course, time is even more important here. So that really means that in the pediatric population, we always use it at a point of care, which means within about 7 to 8 minutes, we have the first results available. And the biggest issue besides, I think, the small blood volume is that we very quickly also overtreat the pediatric population. So when we have algorithms specific for the pediatric patients, it's not so much a difference in cutoff values. I agree we can be a little bit more liberal with fibrinogen, what we even do in the adults, but I think correct dosing is key, of course, in the very small children. So that means in this protocol, of course, we are not talking about a vial of fibrinogen or a bag of platelets or plasma. We always talk about milligrams per kilogram or milliliters per kilogram. So I think that the exactly adjusted dose is really key, because a study, for example, from Boston and Harvard University, so Children's Hospital, showed that if we just give the products, there is a high risk of overtreatment and thromboembolic complications. So that means really we should be careful how we dose. And I think one point for the future, again, in times of COVID-19, is that we have more and more experience also using ROTEM in septic patients or septic neonates. And of course, also now in a viral infection like COVID-19. And again, a viral infection is not the same as a bacterial infection. So we see different patterns, which also might help us in the future to do an individualized anticoagulation. And that's again in COVID-19, where we know that even with anticoagulation, 50% of the patients gets thrombosis. So just giving heparin might not be the right answer. So we have to look at different mechanisms like fibrolysis shutdown, like hyperreactivity of platelets, so that again, knowing more which allows us maybe to individualize also anticoagulation. That's one point, I think, for the future.
Muchísimas gracias a todos nuestros panelistas.
Thank you to all panel members. You've been very kind in answering all these questions and attending this invitation. Thank you, WERFEN International, for giving us this opportunity. Thank you to our team and all the attendees in the audience that have stayed here with us in almost 2 hours. We look forward to next Friday. And for further questions, because we're a bit short of time, we will ask you to address those questions to our YouTube channel, WERFEN Latin America YouTube channel. Please write them there. And we look forward to next Friday at the same time for the next session. If you have any questions or comments that you would like to share with us, please let us know through your local representatives. We wish you the best. Take good care of yourselves, and we'll see you next Friday. Goodbye.
Thanks, Freddie, for kind moderation and all the speakers. Thank you. Bye-bye.